Hello, everybody. I'm Sebastian Seiguer. I'm the CEO of Scene Health. And with me today is Dr. Susan Creary. Dr. Creary is an associate professor of pediatrics and a pediatric hematologist in the Division of Hematology, Oncology, and BMT, and a principal investigator in the Abigail Wexner Research Institute at Nationwide Children's Hospital in Ohio. Thank you so much for joining.
Thank you for having me. Excited to talk with you all today and talk about sickle cell disease.
We are going to talk about sickle cell disease, particularly in children, which is your area of expertise. Tell us about sickle cell disease in general, yourself as a researcher and your research focus.
Gotcha. So sickle cell disease is an inherited hemoglobinopathy or a problem with hemoglobin. The hallmark of sickle cell disease is actually pain. It can lead to devastating pain episodes that lead patients to need to come to the hospital for pain management and ultimately can then develop other complications such as acute chest syndrome. I really enjoyed working with the population of patients who were underserved minorities, which this condition primarily affects here in the United States, and really wanted to as a pediatrician, make a difference early in the treatment course to try and mitigate long-term complications. And fortunately, when I was a fellow, hydroxyurea was a medication that was emerging for youth specifically with sickle cell disease. So there was a large randomized trial that showed that hydroxyurea had great potential and benefit for patients. So that's ultimately how I got to where I was and why I was interested in it. Hydroxyurea is actually a medication that was designed as a chemotherapy agent and used in a variety of other blood conditions. Its primary effect in sickle cell disease is not to treat cancer or other blood disorders. It really works in multiple different ways to keep the red cell healthy. It's a medication that has actually been around for adult patients and approved for adult patients for 40 years now. It's now standard of care to offer that therapy to all patients with severe sickle cell types starting at 9 months of age. We know in adult patients who take this medication, those taking the medication are more likely to survive than those not taking the medication. Can also reduce a whole lot of other risk factors and improve quality of life of the patients who are taking it.
When we're talking about adherence, which is what Scene Health focuses on, in this particular case, especially with kids, the long-term trajectory, the long-term outcomes can really be improved with hydroxyurea, which is why taking it is so critical. And it's also what I find to be very interesting is that there is a marker of successful treatment, which is the fetal hemoglobin. In the same way, there are, other chronic conditions or even infectious conditions where taking medication leads directly to a certain measurable outcome. In the case of sickle cell disease, adherence to hydroxyurea, it's a challenge. The outcomes are vastly improved if adherence is high. Is that right?
Correct. So we know from different studies that we've done that, and our group, but also many other groups around the country have looked at, hydroxyurea is the primary treatment. We don't have many other therapeutics. And so people have really focused on how do we effectively and optimally use it. We found that in children, more than 50% of patients take less than 70% of their drug. So there's clearly an opportunity to optimize that amount of drug taken. And clinical trials are always biased to patients who already do and are able to consistently take their drug, which is not the real world setting and true for the vast majority of patients. We know medication adherence is a problem across the board for all chronic conditions, and in sickle cell disease and children specifically, hydroxyurea can be really challenging to take. And that can be for a whole host of problems and a whole host of reasons. Number one, hydroxyurea is a medication that doesn't work all that quickly. So what you're trying to do is affect the types of hemoglobin you make. That can take months. It also depends on the dose that's prescribed, and that dose has to be adjusted and titrated over time and can depend on how consistently somebody's taking it and then their individual response. Some patients may start taking a medication for like hydroxyurea before they even develop a whole lot of symptoms. And so we know medications where patients can perceive the benefit. So they're having issues and then the medicine starts and then they perceive that benefit. They're more likely to consistently take it. Some patients, the idea is to start the medication before you have those challenges. So we also know that these patients are often underserved, impoverished, and face many other challenges on a daily basis. So prioritizing a daily medication in the milieu of a very busy home life can also be quite challenging. And then there are also, finally, many of them, especially the younger children, are dependent on a caregiver. So the caregiver has to, administer the medication and remember to take the medication and get the medication prepared for their child. And then in pediatrics, we worry about just trying to get a medication into a child. And so that can be challenging as well. Sickle cell disease is inherently a very episodic disease. So patients most of the time are feeling well. They don't feel like they have a chronic disease that can be, very severe and even life-threatening. It happens at the inconvenient times that complications occur, but in between, it is challenging sometimes for patients. So that can lead patients to think, oh, I'm not, just because I'm not having complications, that's when adherence might start to wane and you're like, I'm feeling fine. But it's more of a longer term reflection of how well they're doing. Am I overall feeling better? Are my lab markers looking better? Are there ways we can objectively measure how somebody's feeling and doing better? Really, I think is needed to help support patients long term, even after a period of, intensive intervention.
Everybody's been talking about gene therapies, and the promise of a silver bullet type of cure is always interesting. So perhaps you could compare the differences between what gene therapy offers, besides, of course, being a cure, but how would you compare the strategies of a daily medication, which will have to be taken over a longer term, to the promise of gene therapies?
The gene therapy products range in over from $2 to $3 million, and that's just for the gene therapy product itself. So the costs are quite high, and really in an underserved minority, impoverished population where the bulk of this is actually not here in the US, but in sub-Saharan Africa. Although that cure potentially exists, the actual ability to access it might be quite limited. Something that I've definitely learned, this population is used to having their sickle cell disease and used to having limited treatments for their condition. And so it has taken decades to get a large proportion of the population to accept treatment with, for instance, hydroxyurea. And so I envision something as space age as gene therapy, given all of its risks and challenges and costs, to also take a long time to trickle down and be something that's widely available. And then we still have a lot to learn about how to mitigate the costs and the challenges. And so I think that decision is still a very personal decision. It's not something that I would say a patient should have gene therapy. Is something that we could offer, but the vast majority of patients that they're not even at a stage that that's something that they would pursue. Although it's something that's exciting and I think holds great potential for the future, the vast majority of patients in the world living with sickle cell disease are really going to be more dependent on a medication that can mitigate rather than potentially cure their disease.
It seems like hydroxyurea or other medications are at least in the next 10 years or 15 years, the standard of treating this condition.
Absolutely. So patients generally, after they're born, they're not headed straight out to a curative option. We want to see how severe their sickle cell disease is, but a way to mitigate that is hydroxyurea, and whether or not that would be an option they would want to pursue might depend on how well they respond to hydroxyurea. We can only know that as best that they can consistently take their hydroxyurea. So I think it also informs their decision making. And I tell all my patients who are interested in, even when they're interested in pursuing a curative treatment, that absolutely in the meantime, while we're thinking through and working through that process, and if that's going to ultimately be their treatment path, we should be doing everything in the meantime that we know is effective, and that includes hydroxyurea.
you are an expert and a pioneer in a very specific way to support adherence, which is referred to as video directly observed therapy. And for background, directly observed therapy is standard of care actually for all medications in the inpatient setting. In the hospital, all medications are given under directly observed therapy, which is when a healthcare provider, nurse, physician is with the patient when they take medication to make sure it's actually taken, it's the right dosage, it's the right person. In certain situations, and this has been used for asthma, for substance use disorder treatments, for infectious disease treatments. At Scene, we're using it for hypertension, for congestive heart failure, COPD. Tell us about how video directly observed therapy works and your general thoughts on video DOT as a strategy.
Yeah, so I think when I was first learning about, adherence to medications and thinking about my population, the answer always is, why don't people just take their medication? It's what's prescribed. And I think there's just so many challenges, right, to that people don't recognize in taking a medication like hydroxyurea. So when I was thinking about different options for things that we should trial, obviously came to directly observed therapy. As you mentioned, it's pioneered as standard in the hospital and was used initially in the treatment of tuberculosis, and thought, now can we adapt that and make it something that would be more feasible in the outpatient setting and also acceptable in the outpatient setting. And I think, the real benefit of video DOT is that it allows patients to get the support that they need. It also allows an objective measure of their adherence. People can get to know the patient, but it can be done very efficiently as well. So it would not be feasible to go door to door to watch every patient take their hydroxyurea every day. Although that might provide great support, it's just not something that would ever be feasible or cost effective to do. But technology, fortunately, has made it very possible. Patients seem to really appreciate that connection that they have with another human, whether that be in person or actually via video technology.
It wouldn't be feasible to go to somebody's home or have them come to you every day for their treatment. But I also understood that you didn't even think you could do that on a live video as well, right? You went to a different type of video directly observed therapy using video recordings.
Correct, to allow for flexibility. So we knew our families and patients, this is the drug hydroxyurea is once a day. We tell them as long as you get it in the day, that might be for some patients at 6 a.m. and some patients at 10 p.m. It really doesn't matter. We just want them to get it in once a day. And so thinking about how you would feasibly do it, as long as the patient got it in and it was video recorded, that feedback could be done. It didn't have to necessarily be in that exact moment. It just allowed more flexibility, both on the patient or caregiver to administer their medication, but also from the perspective of the team that's tracking them, which just really wouldn't be feasible to insist that patients take their medication during business hours, for instance, and that would be quite disruptive. So it allowed for, a single person as well to be able to monitor a lot of different individuals, right? So they could, instead of taking the time transferring to different houses or taking phone calls intermittently throughout the day, they could sit down, watch a short video clip of patients taking their medication and track them and continue to move throughout the day and monitor way more patients they could in person.
Yeah, and the sickle cell disease with this particular treatment seems like an ideal use case because of that, the lack of the pressure on the timing. I think, as I've understood, you're trying to get to a level of hydroxyurea versus, for example, when we've worked in transplant, you have to get the therapies in sometimes 3 times per day and on a pretty strict schedule, which that has its challenges as well, right? So you're talking about 2-3 times a day videos. It can still work, but the nice thing with hydroxyurea, or if you think about pediatric asthma, has a similar dynamic. Sometimes the goal is just get the child to use their controller inhaler once a day at the least. In one of your studies, so during that intensive period, you've got a daily source of information as to whether the patient's taking medication or not, but also an engagement with the person. So in terms of the burden it puts on you, your team, there's a video coming in from a patient. You have many, many patients using this technology and intervention. So what is that burden on you to engage back with the patient? What can a provider do, especially given that this is a relatively small population that's spread out all over the country to many different providers and care
Yeah,
teams?
I think that's a challenge that, we've been faced with, like how can we deploy it and scale it? Patients are few and far apart, and although we've tried to make it as efficient as possible, clinical sickle cell teams and nurses and physicians are busy seeing patients and dealing with the acute issues as they occur, and really have, to dedicate 30 seconds every day to each patient taking their hydroxyurea is probably within the healthcare system not feasible, and also maybe not even the best use of resources. I will say physicians and nurses, there are very few of us who have been trained in adherence and how to promote and support people in adherence. And so a group of people delivering support and adherence support who understand the challenges and can give positive feedback and ways to overcome, adherence problems are probably much more efficient at doing that. And physicians doing that oversight, or even members of the clinical team, that's stuff that we're not as well equipped to manage and train and to help train our patients how to do. So I think, we've learned that it doesn't necessarily have to come from us. Now, we would love to have that information back to us, because that informs our decision making about how we take care of patients and how we offer them therapeutics and how we adjust their medication. But it's something that I think we as providers just would overwhelm the healthcare system for us to do that on our own.
Right. And I think you learned that from your first studies where your team was doing things. And of course, in the most recent study, our adherence team, and it's nurse-led, is doing the review and the engagement, and we're centralized so we can do that very, very, very efficiently and apply technology to that review and to that engagement. But I think that you've got that right, that what's the role of the provider? That includes, of course, nurse and physician and pharmacist. It's not a daily appointment for a long period of time. That would be impossible to scale. I saw that you compared the adherence type measure you were getting, or the data you were getting from video directly observed therapy, to a possession metric. So in the health plan space, in the payer space, medication adherence, they use a proxy measure to capture it. And it's often a possession metric such as MPR, the medication possession ratio, or PDC, proportion of days covered, essentially measuring how often somebody's refilling their medication. How do you find video directly observed therapy in comparison to an MPR measure or PDC?
Yeah, so directly observed therapy, there are a couple gold standards for measuring adherence, and direct observation is actually one of those gold standards. So you're watching the patient do exactly what you're trying to measure, take their medication. But we also wanted to know, as we're thinking about interventions and how are we going to measure their impact in comparison to another group, we needed to say, what is a measure we could use for groups that weren't getting observed therapy, for instance. So one of the things we wanted to do was validate refill records, and looked at the refill records, or MPR. How well do they correlate with the observation? And we actually found that they didn't correlate very well. And then as we thought about it and how we see patients and what we think about how patients behave, how they refill their medication, the dose of hydroxyurea can change throughout time. Patients can get a refill and have a stockpile of medication at home, and they may do a really good job taking a medication for a certain period of time and then not so well. And so you're not getting a great reflection of what their most recent adherence is. So that kind of puts some limitations on refill adherence. It is potentially one way to estimate adherence, but we haven't found that it's really all that accurate in people with sickle cell disease. And so other measures like observation are potentially better at quantifying how much drug a patient is actually taking.
Right. It's interesting that when you look at the refill measures, you'll find that they do a really good job of telling you if somebody is not taking medication because they simply don't have it, right?
Mhm.
Especially if you've eliminated the stockpiling, so past stockpiling. But the patient that actually has perfect possession, meaning they've gotten all their refills, if that patient isn't taking any of their medication and they're stockpiling it, it is the least accurate possible way to measure adherence. And adherence is the extent to which medication is taken as you've prescribed it, Dr. Creary,
Mhm.
not
Mhm.
whether you've refilled it. I've got one final question for you.
Yeah.
As you look at the various options that are on the table right now for sickle cell disease treatment, and you think about the kids that are so lucky to have you and your team helping them, and the kids that are going to be born with this condition, what does treatment and management of sickle cell disease look like 5 to 10 years out from now?
Yeah, so, I think we're going to continue to learn more even about hydroxyurea. We're learning about how to dose it and titrate it and efficiently use it both here and in other lower resource settings. But there are emerging therapeutics on the table. And, we talked a lot about gene therapy earlier in the call and how that holds a lot of potential, but also holds a lot of risk. I think the menu for sickle cell treatment is going to continue to increase, and a large portion of that menu is going to be oral medications. So we'll learn how not only how to better titrate hydroxyurea, but how to use hydroxyurea in combination with other therapeutics. There are another oral therapeutic that's been approved, and there are a few others that are kind of advancing through clinical trials that really hold a lot of potential. Again, hydroxyurea and these curative therapies have not been compared head to head. My thought is that they'll probably end up being compared multimodal medication to those transformative curative therapies. And so with that, I think that holds a lot of potential of we need to figure out how to address and efficiently and effectively deliver those oral medications because they may be what patients ultimately choose that they want to do given the risks of curative therapies. And so just really to open up the menu for patients. I think patients are finally they're wanting more options, and more options include helping them to use the options that are available most effectively. So
Yes, and what I love about this conversation is you're talking about how to dose, how to titrate, patient by patient, and this really seems to me like, and it's day by day. It's not over, seeing a patient 6 months later and then learning about it. This feels to me like what precision medicine means,
mhm.
and I think that a future where there are multiple options, there are options for different types of patients, and we talk about levels of fetal hemoglobin and how many doses they took and what time of day. Those are the things that we still have yet to learn, and can learn a lot using research like you are currently doing.
We're excited about the potential for really being evidence-based and taking all the data points, right, to titrate it to what's the best therapeutic for the patient to achieve the best outcome for them over their lifetime. And I think in children that allows, if we can do that early in the treatment course, that really allows the patient to be most successful and live their best life as they age into adulthood.
Excellent. Well, Susie, thank you so much for taking time for us today and also for dedicating your career to people who really can benefit from incredible therapies that are out there. So thank you so much.
Thank you very much for having me. I really appreciate it. Thanks so much.